Hi, my name is Dr. Charlotte Horne, and I would like to thank America's Hernia Society for the opportunity to present our research, Understanding the Benefits of Botox, a retrospective analysis of the America's Hernia Society Quality Collaborative. My disclosures are not relevant to this research. Large incisional hernias present a set of unique challenges to a surgeon, as these hernias are often associated with limitations in either abdominal wall compliance, abdominal capacity, or a combination of both. While the exact definition of loss of domain remains subjective, abdominal core health surgeons generally agree that achieving primary fascial closure in the repair of these hernias is associated with decreased postoperative morbidity and a lower recurrence rate. In order to facilitate repair of these hernias and mitigate some of the limitations associated with these cases, different preoperative optimization procedures are being investigated. One of these is preoperative chemical component separation with botulinum toxin. This is because there is radiologic evidence that it increases the length of the abdominal wall muscle and decreases defect size when administered. Despite its increasing utilization, much of the understanding of its benefits that we have is limited to case series, and there is a paucity of data which objectively evaluates the benefit of its use. The aim of our study was to determine whether or not preoperative chemical component separation with botulinum toxin A improved primary fascial closure rates. In order to answer this question, we queried the AHSQC database, which is a prospectively maintained surgeon-entered database. We looked for all patients undergoing an elective hernia repair for a defect greater than or equal to 15 centimeters in width, who received preoperative Botox. Propensity score matching was then used to match these patients to a similar group of patients that did not undergo a preoperative component separation in a 3-to-1 ratio. These groups were matched for potential factors that might affect fascial closure rates, including age, BMI, ASA, CDC class, presence of a stoma, and recurrent ventral hernia or history of an open abdomen. In total, we identified 97 patients that received botulinum toxin A and compared them to 291 patients that did not. Descriptive statistics were utilized to characterize the study population. Comparisons of proportions were performed using Fisher's exact test or Pearson's chi-square test. A two-tailed p-value of less than 0.05 was considered significant. In our study, our primary outcome was fascial closure rate. Secondary outcomes of interest included 30-day postoperative outcomes, hernia recurrence, and quality of life determined by NIH PROMIS 3A and Hercules scores at 30 days and 1 year. The table demonstrates the patient and hernia characteristics between the two groups after propensity score matching. There was no statistically significant difference in hernia width or length. Approximately 50% of patients in both groups had a grade 2 hernia as determined by the modified ventral hernia grade. Slightly greater than 50% of patients had a recurrent hernia in both groups, and 30% of patients in both groups had a history of an open abdomen. As expected, these cases were complex, demonstrated by the fact that all patients in both groups had an open approach, and an overwhelming majority of the cases lasting more than 2 hours. 2/3 of the cases in both groups were CDC Class 1. While not used in 100% of cases, mesh was utilized in a significant majority, with no statistical difference in mesh size between the two groups. Interestingly, a biologic mesh was more commonly used in the pre-op chemical component separation group when compared to the non-chemical component separation group, where a permanent synthetic mesh was more frequently utilized. A myofascial release was only performed in approximately 3/4 of patients in both groups, and while the performance of a myofascial release did not vary between both groups, the type of release did. Patients in the chemical component separation group were statistically more likely to undergo an external oblique release compared to those in the non-chemical component separation group, who were more likely to undergo a retrorectus release or TAR. Fascial closure rates were not statistically different between the two groups, with it being achieved in approximately 80% of cases whether or not a preoperative chemical component separation was performed. There was no significant difference in postoperative morbidity between the two groups. Both groups had a 9% readmission rate, a 4% reoperation rate, and a 0% recurrence rate at 30 days. Wound events were also not statistically different between the two groups. Quality of life outcomes did not differ between the two groups. Both groups had a small increase in pain as determined by the NIH PROMIS 3A score at 30 days, but returned to their baseline at 1 year. Hercules scores were used to determine quality of life, with a higher score indicating a better quality of life. Hercules scores were significantly higher in the non-chemical component separation group initially. However, both groups had an equivalent improvement in quality of life at both 30 days and 1 year. I would like to mention a few of the limitations associated with this study. First, as this is a retrospective analysis of a database, some of the nuances associated with the management of these complex hernias cannot be evaluated. The administration of botulinum toxin is based entirely on surgeon discretion, and so it is unclear if these defects could have potentially been closed in the absence of its use. Further evidence of surgeon discretion in the management of these hernias is evidenced by the fact that the type of component separation between the two groups was significantly different. This is likely unrelated to whether or not the patient received botulinum toxin preoperatively, but more likely due to surgeon preference. Secondly, postoperative follow-up, especially in the chemical component separation group, was severely limited, which limits the interpretation of these results. In conclusion, our data demonstrated that preoperative administration of botulinum toxin A for defects greater than 15 centimeters did not result in an increased ability to achieve fascial closure. Ultimately, it shows that there is a limited understanding about the optimal patient or hernia characteristics that would benefit from potential preoperative administration. As our data suggests, the approach to these complex hernias is based on a surgeon's judgment, with limited prospective data to guide the decision-making. I think ultimately this demonstrates a need for further research to understand if and or when administration of botulinum toxin A preoperatively provides an improved outcome. Thank you for this time to present our work.